My name is Michael Battelle, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risk, causes, and complications of fatty liver disease and help those already diagnosed with mast cell MASH by advocating for access to approved treatments and care. Our very special guest today is Professor Francois Pattou, who's the head of the General and Endocrine Surgery Department at Lilly University Hospital and the director of the Diabetes Translational Research Laboratory. Professor Pattou, you and your co-researcher, Professor Stefano Romero, are literally shaping the future of fatty liver disease treatment with your recent finding. You have identified two distinct subtypes of MASH, and your study was just published in Nature Medicine and marks a pivotal shift in the understanding and treatment of NASH. I'm very excited to hear more, as our followers are, I'm sure. Please fill us in with what drove your research and what you found.
Hi, Mike and followers. A real pleasure to be with you today and share our results, which are, we think, quite exciting. So I hope you're right and we'll shape the future. I don't know, but at least inform the future with a different view. And just to start, I would like just to briefly give you a history of where these things started. Sure. So by training, I'm an endocrine surgeon. So I'm doing metabolic surgery. So we are treating people with obesity who by chance or by unchance have MASH for many of them. And so we've been looking at these patients for 20 years, closely, years after years, and have a lot of data gathered from these patients, 2,000 patients now. And that's where we can start to do data-driven science. Data-driven science is something pretty new for the field, but it's not new for you because it's everywhere in your phone, everywhere with this big data science that drives our lives today. So this is where we started. So that's the paper I'm going to show you today. I'm just sharing the screen. So this is the paper. This is the first author. So it's a 3 years work of 4 brilliant young scientists that shares their efforts to do that. And with my friend Stefano Romero from Karolinska in Sweden. And we work in France, in Lille. So the thing is that data-driven science, data-driven clustering is just an idea of let the data speak just by themselves to organize what we think being only one disease called MASH or MASLD in the simple form, and to uncover maybe more subtle subtypes. And that's what the data says. So what we did, we use classical clustering techniques. So that is something that you think intuitively you could do yourself, but human brain cannot use 6 variables at the same time and organize them. We can do that with 1, of course, with 2 sometimes, but never more than 3. So here we chose 6 variables, quite simple. All were selected because they are involved in one specific aspect of the physiopathology of the disease. So you can recognize A1C, which is diabetes, ALT, which is liver inflammation, LDL cholesterol, and triglycerides, which are lipids, BMI, obesity, body composition, and of course, age. So these data, we let them, from 2,000 patients, we let them speak together, and they clustered in 6 homogeneous groups, meaning subgroups that look alike. And so, as you can see here, there is 6 different groups of patients, and 2 of them I would like to focus on, the blue and the red. So the blue we will call later liver-specific MASLD, and the red we call cardiometabolic MASLD, are characterized for the blue, for the liver-specific, by high liver inflammation, younger age, lower BMI. But the red one is characterized by an older age, a lot of diabetes signs or diabetes symptoms, and high lipids, triglycerides. So that's where we go. And so we now go from these groups. So I just leave the other one together alone. That's the control group altogether. And we focus on the red and the blue. And if you look at these 2 groups of patients, and we now go to the liver histology that was available to every patient in this cohort, you can see that these 2 groups are very high level of MASH incidence or MASH prevalence in these 2 groups. And interestingly, we now have validated that in 3 other European cohorts with liver histology available, and we found exactly the same 2 groups associated with a very high level of MASH, so the severe form of MASLD. So that was interesting. Interestingly also, we went then to the UK Biobank. UK Biobank is a very interesting, nearly nationwide cohort in UK, England, And from a lot of patients that have been just followed for years and have been scrutinized as we did for our surgical patients, but that's general population. And several thousand of these patients had MRI, imaging of the liver. And if we now look at our clusters, so the simple variables I told you, we found the same two groups, of course, because it is general population, the prevalence of these two groups, the number of patients in this high-risk group are slow because it's general population. Remember that before we worked with patients with severe obesity with a lot of risk for NASH to start with. But in this general population cohort, you can see that these two groups exist, they look alike. And again, when we look at the imaging that was available, no liver histology in this population, again, you have this very high proportion of MASH. So, but what is even more interesting, because if we now stop for a minute, we can see that we have two groups of patients, the blue and the red, cardiometabolic, the red, liver-specific, the blue, who have the same liver. Let's say that if we look at imaging, if we look at liver histology, they look alike with the classical histological classification. But if we now look to the outcome of these patients, we follow them in this UK biobank, it was possible because these patients have been followed for nearly 15 years. You can see that both of these groups, and that makes sense, will have the same incidence of chronic liver disease event, meaning that they have a bad liver or diseased liver, and they will have some classical chronic liver disease, such as it could be cirrhosis, it could be many others, cancer of the liver. But if we now look at the cardiovascular disease, and we know that MASH is globally associated with cardiovascular disease, and that's most often the cause of the death in our poor patients that have with this very severe disease. This is striking that one of the group, the cardiometabolic liver, is really dying or experiencing cardiovascular disease. But the other one, which is this liver-specific group, seems to have no specific risk of cardiovascular disease. And if you look at the type 2 diabetes incidence, so in the patients that had not diabetes in the beginning of the study, and we are looking at the new case of diabetes occurring, you can see that as expected from the red group, we'll have a lot of incidence of type 2 diabetes, but in the blue one, much lower, but a little bit, which is maybe interesting, but this is a more detailed aspect of the study. So if we now look very interestingly at the genetic, and genetic is important because genetic starts the story. It's always the beginning of the story. You can see that only the blue group is associated with this very classical risk factor, genetic risk factor variant for severe liver disease, which is PNPLA3. And you can see that 2/3 of the patients in this subgroup will have these variants. And that's much higher than in the control group or in the cardiometabolic group. You can see also that there is no increase of the genetic variants in the cardiometabolic disease when there is MASH at liver histology. Same data in the UK biobank were found. So to make this long story short, and I will not go further, maybe we can have discussion later, what we found, what we propose, is we are facing not one disease called MASH, but two subtypes of the disease. So it looks alike when you look at the liver, but they are very different. And they are very different because one is liver specific. So the liver is the cause of the disease. It is genetically driven. And there is specific biology behind that, which is the liver is producing and not processing correctly the lipids. So is overwhelmed with lipid from inside. When on the other group, the cardiometabolic MASLD, the liver is the victim of the systemic hyperlipidemia, hyperglycemia, so of course diabetes, and is the victim, and at the end is becoming also overwhelmed with fat, but for a different cause. And what is important, they look alike in the middle in the liver, but they are coming from different biological mechanism, and they are going to different clinical outcomes. So that's the story. And again, just before I finish, I would like just to underline that this is possible just for this data-driven cohort science that has been possible with the generosity of these hundreds, it's 2,000 now of patients that are coming with us and giving time, but also suffering, because it's suffering to give some blood sampling and to take time with us for all these with the these results, and we've been very happy to share this time for the whole 2 last decades with all these patients and the team. So this is our story. And I would, of course, be very happy to explain some specific points if you have questions.
Oh, for sure, I have questions, and thank you. So when you stop sharing here, we'll jump on the big screen together. There we go. Thank you. Okay, so first of all, it's very, very exciting, and right away my mind goes to how can we use this in the real world, right? Discoveries lead to progress like that, and we try to represent the patient's voice at the end of the day and say, okay, so what can we do with this? So my first question is, how easy is it, or might it be at some point, to screen for the differences between the two groups that you have?
So diagnosis or screening is quite easy. You just need 6 variables that I've just told you: age, BMI, ALT, A1C, LDL cholesterol, and triglycerides. These variables are available in every clinics, every cohort. So this is easy. You just go then to the online calculator that we've been made available. It's totally free, and everything is on the paper. So you can just go there, put your numbers, and you'll see if your patients fits to one of these 2 groups. So that's the easy part. Now that we don't know and we expect is that these 2 groups are not just like classification, they are useful. And what we think is that these 2 groups, because they have different biological underlying mechanism, will respond differently to the treatment. And that makes, of course, a lot of sense. We know now that the treatments that are proposed are efficient in only part of the patients, sometimes half of the patients, sometimes a bit more, but not all the patient answers. And we think we can give an insight to that.
Okay, so that's a great point. That's not one of my questions I was going to ask, but I will ask that one first. So you have the treatment side. So in a best scenario, if you're looking to enrich the treatment population group, you would do the assessment before, and really you would expect a much higher response from the treatment that's on the metabolic side, right?
That's the point. And so it will be easy to check now, because we have a lot of trials with a lot of data available. And so what we are now interacting with is other colleagues or companies that have data, and that will be able to check back in their data if they classify the patients in these 2 groups, if they found different outcomes between the 2 groups. So that is going to be happening in the coming weeks and months. And then, of course, on the prospective study, using this information will tell the truth in the long run.
Okay, I wanted to ask this. So I also think that if patients turn out to be, if they go through this assessment, if they turn out to be on the metabolic side, then for sure they should also be assessed for cardiovascular risk and type 2 diabetes if they haven't already. Correct?
Exactly. That's exactly the point.
So that would be a big change to the way that patients are assessed now. I think we're still in the early stages of MASH and learning, which is obviously proven by the work that you've done, how we can improve that assessment process and try to streamline, and even in some ways reduce the number of patients that are being referred to specialists as well. Or which specialists they would be referred to, probably even more appropriate, right?
Absolutely. And it is very likely that we are now discovering that what we call MASH today is very different if you are considering a diabetic clinics or in a pathology clinics. What we expect, and we've seen it in the validation cohort, is the prevalence of both of these groups are very different. If you are in a diabetic clinics, patients will come to you because they have diabetes. And so most of them will belong to this red group, to this cardiometabolic group, when in the liver clinic, it will be different. So this is what we expect. Of course, I think we are just opening a door, a very nice and potentially big door, But now a lot of people are going to jump on that, and I'm pretty sure we are going to be challenged. There will be controversies, but I think it's a strong door, a strong avenue to be opened. May change at the end of the day with a lot of people working on it the way we do, but this is an opening, and I think that's an quite enthusiastic opening to something more
For sure.
operational for the patient.
For sure. And I was very touched with the image that you shared, recognizing the patients that were part of your research. And I know it's difficult for patients, the commitment that they have to make over a long period of time to be able to work with that. So thank you for doing that.
Yeah, just it's an amazing picture because that's every day, every year we do that. It's patient day. And it's a
Yeah.
funny thing. We just see the picture, but the day before, the morning before, it's a specific event where we invite all participants and invite the researcher, the scientists that have worked on the samples, on the data. And their task is to explain to the patients in 15 minutes what they've done. And it's an experience which is on both sides very amazing. So I can tell you it's every year, every spring, and it's very good.
That's fantastic. It's true that what we've learned through our research and discussions with patients is that they really want to understand more about what they've contributed to. So, kudos to you and your colleagues and your team. Thank you so much for today. I know we're going to be talking again. This is the first time that we've had you on our Fatty Liver Alliance Zoom discussion, and looking forward to doing more of these. And thank you very much for the contribution that you've made.
Thank you very much, Mike.